Good morning. My name is Spelanza Wahome. I'm a trained nurse working at the MCH department. And today we are going to look at the ABC assessment and treatment of infants and a child with sense of life. Maybe you're the clinician, you're the nurse who is working at a certain health facility, and you've been brought for a child and you need to do the assessment, the ABCD. As you know, this week we'll be being taken through sessions, sessions of how you're supposed to deal with maybe a collapsed child, a collapsed grown-up, or a child who's come with no sense of life. So meaning you have to resuscitate. And that is why we felt it's very important to first assess this child so that you can know what next you're supposed to do as you deal with this kind of child. So the objectives of today is to learn how to make the initial assessment of a sick child and how to make an immediate decision, because that is where it all starts. So the initial steps, once you've got this child, what are you supposed to do? Of course, even when they are already in the line, they're yet to get to you. You know, our waiting base, you're supposed to observe, is this child alert? And how are you going to know if a child is alert? This child might be interested in the surroundings, because an alert child is always, they will be looking at something, they're interested. A child is always very curious, so they will want to touch things, see colors, and then check if the environment is safe. Because of course, you're not going to deal with this child if you yourself or the environment you are working in is not safe. And then if this child is not alert, what else do? You need to stimulate this child. Like there are those mothers who will come and tell you, my child has stopped breathing, or I don't know what is wrong with my child. And as you stimulate to see if you have any sense of life, you don't work alone. Now there you can shout for help. And as you shout for help, you're supposed to, the mother is the one who's holding this child, or just the mother who had, or the relative, whoever brought the child to the hospital, you're supposed to change the settings from the mother, from the mother who is holding this child, or from the person who is having this child, take the child and maybe take to the resuscitation coach, or take somewhere safe where you can continue assessing this child, or you can continue now helping this child. And immediately you get this child, after now you have observed them, you've made sure that your environment is safe for you, for the child, and then now you get their airway. Check how their airway is. Do you need to clear this airway? And remember, these days when we are clearing the airway, you only clear what you can see. Don't do the deep sanctioning. You only clear what you can see. If there are any secretions, make sure that is the only thing you are sanctioning. If it is something that is obstructing the child's airway and you are able to get it out, but don't deep sanction or clear the airway where you cannot see it. And then does this child, as you clear the airway, will they start breathing? Because most of the times, if it's something that was obstructing the airway, maybe the secretions, this child might start breathing on their own. But if they are not able to breathe on their own, you need to support that breathing system. How do you support this breathing system? One, you can position this child. We have seen in some instances where you only need to do maybe a head tilt, putting the child in a sniffing position, and they start breathing on their own. Meaning now you've been able to at least deal with their breathing, and they will start breathing on their own. And then if they're not breathing on their own, even after you have positioned, what else do you do? You support them maybe through oxygenation. That is for the child who had signs of life. Of course, if they didn't have any signs of life, you're supposed to start now resuscitating with the bag, valve, and the mask. And then if you have checked the airway and you made sure that now the airway is clear, this child the airway is supported, you go now to assess for the breathing. Check if this child is breathing. Of course, to check if they are breathing, you can first look at them. Of course, you're going to see if their chest is rising. If their chest is rising, that is a good sign. But how is it rising? Is this child having any chest indrawing? Because that means their breathing is not adequate. And if they're having any chest indrawing, you need to continue supporting them with maybe giving them more oxygen. Or are they breathing with their muscles, with their abdominal muscles? Meaning that they are having some acidotic breathing, meaning you also need to support their breathing. That is, if they are having any chest indrawing, if they are having any deep acidotic breathing, and then if the child, you had assessed your child and you had seen that the child is alert and they're having some breathing, but is this breathing adequate? How do you assess if your breathing is adequate? You're supposed to check if they're having any head nodding. You know, there are like some children who, if they're not having adequate breathing, they'll be nodding their head. The way they are taking in their breath and out, you'll see that their head nodding, you know, like their head is like, it's moving like the way my head is moving. So if they're having any of that head nodding, you know that their breathing is not adequate. So in the airway, how do you assess for it? Is this, if the child is alert, you listen if they're having any noisy breathing. You can feel like maybe the child has come with something like an asthma, and you know their airway now they are constricted. That means they'll be having some noisy breathing, and you'll know if they're having any noisy breathing, that is not something normal, and you will need to support their breathing. And then, do they have any stridor? We had already said you are checking if they have any obstruction or a foreign body that you're able to remove. And if not alert, that is, we had already said if the child is not alert, move the child or the infant to a couch or a bed where you can continue now checking or assessing them. And then you look in the mouth. Is there anything that is obvious obstructing their airway that you remove? And then you position or support is airway support positioning, or is there any support that is needed? In case there is any support that is needed, of course, you do the necessary and support, either with oxygenation, and then we are going to see how you can give the oxygen. Yeah, okay. Now that is just a child who was there, who had needed to be supported their airway. So that now shows how you're supposed to position the head. This is going to be shown consequently in the simulation sessions, how you're supposed to open their airway in a sniffing position where you do a head tilt. That means you just do a jaw thrush, just a little jaw thrush with your fingers. Of course, you don't use a lot of force. And then you support their head by placing your palm on their forehead and just tilting a little bit backwards, and then you put them in a sniffing position. And then a rapid assess of the breathing. Where should you assess for this breathing? Because you know inadequate breathing results in poor delivery of oxygen to other body parts, and this can cause altered consciousness level. It can result in complete collapse. That is respiratory arrest if you don't treat it very early. That is why it's always very vital when you get this child. You're supposed to do the rapid assessment, because this mother brought you the child because they saw there was a problem. Make sure you attend to them very fast, and that is why we are going to see why it's important to triage. You attend to them very fast before all the other children, because if you don't, you're going to cause more damage, and this child can go into respiratory collapse. And then for assessment of the breathing, how do you assess for if their breathing is adequate? You check for central cyanosis. You can do the respiratory rate. Is it very fast? For the central cyanosis, we always check for this child is darker or is dark. This is not a brown child. So you check inside the mouth. You either check the tongue. The tongue is going to appear bluish, or at the jaws, they can also appear bluish. Never check at the lips, because that can be a bit confusing for a child who is dark. So you check their tongue and maybe their jaw. Also, their palm and their feet. That one can also confuse you, because they might be dark, so you're not sure if this is their normal darkness, you know, their skin color, their normal skin color, or this is a bluish color. So always check for central cyanosis. Count their respiratory rate. Is it very fast? If you have a pulse oximeter, of course, this is available in most departments where you're having the children, or even about the adults. I think we all have the pulse oximeters. Take your pulse oximetry, and then the respiratory effort. Do you have any grunting sounds? Do you have any head nodding or bobbing of the head, the one that we were talking about? Do you have any chest indrawing, or is this child using their their abdominal muscles to breathe. That is, they're having deep or acidotic breathing. Is their chest moving in a systematic manner? Do they have any quiz? This is something that you're able to feel. How is this child? Is this child alert, or are they gone into unconsciousness? That is where you assess with your AVPU. So if they have a very slow breathing or gasping, you may require now to start the bag valve with mask ventilation. Of course, if they are, the best saturation is if it's over, the SpO2s are over 90. If it's 99, of course, anything above 90, you're happy. If it is anything below 90 in the presentation of your child, of course, now you start making your decisions to give the oxygen, to supplement with oxygen. So in case your pulse oximeter fails, because at times you go to work and everything seems to be working against you, what do? You don't just sit there and start moaning or start saying, let's get another pulse oximeter from elsewhere. You need to start doing something. So have you seen like the central cyanosis, all those signs that we talked about, any grunting, head nodding, severe lower chest indrawing, fast breathing, that is more than 70 beats per minute, and is your AVPU less than A, or inability to drink plus respiratory distress? Of course, there you proceed then, just give your child the oxygenation that they need. And then consider oxygenation even if your child is not having any of the above signs. If they're having any wheeze and inability to talk, that is if they are of talking age, and if they're having any deep or acidotic breathing. So in case you don't have those signs above, but you still have any wheezing or they're not able to talk, and they're child of talking age, and they're having any deep or acidotic breathing, make sure you supplement with oxygen. And then here you can administer your oxygen. This is where we had said you consider how you're going to, according to your SpO2s, according to the presentation of the child, how much oxygen do you need to supplement with. You can either use the nasal catheters or the nasal prongs. Those ones are readily available. Just make sure in your department you have the different sizes according to the children or the age of the neonates that you're dealing with, because those ones are going to give you around 30 to 35% supplementation of oxygen. And then you start with between 1 to 2 liters per minute. Of course, if the oxygen is between 90 to 97 and you feel like you need to supplement it, and you go increasing it to a flow of 4 liters per minute, make sure you follow these, how many liters per minute you're supposed to give, because you also don't want to intoxicate this child when you are giving oxygen or destroy their brains. And then if there's a little risk, that means you monitor for the abdominal distension. In case you're giving oxygen, but the child starts getting any abdominal distension, make sure you first discontinue the oxygenation or lower the rate at which you're giving them. And then for the newborns, always start with 0.5 liters per minute, go to a maximum of 2 liters per minute. And of course, you continue monitoring your SpO2s, stop whenever need be, and reassess. This is just the normal mask that we usually have. Of course, we have this fast mask that does not have a bag. It doesn't have a receiver. So in case you have the one with a receiver, make sure, and they're readily available in our stores. So order, make sure you're giving the child with the one with a receiver, because of course we know about their breathing, and then the one without a receiver, that one you can always use in adults. So for very severe respiratory distress, other supportive measures that you can do, you can position this child, or you can position, if it's a child who is able maybe to sit upright, you can prop them up or forward, and then ensure that when this child is on oxygenation or you're supplementing them with oxygen, do minimal handling because of the distresses that they are having. You don't have to keep, being there, you're turning them. Just do everything at once. If you're taking your vital observations, your temperature, because of course, we know every time that you're handling them, they are also uncomfortable and they might start moving, and we want to ensure that they are really resting. And then do assisted feeding or maintenance, fluids, and then give high flow nasal catheter, oxygen, whenever you're supposed to do it. Keep processing your child and support. Don't only concentrate on your breathing, continue supporting even the other systems. So most common cases of circulation failure in Africa, most of the times it's dehydration and severe anemia. And as we had said about severe anemia, like you can see, that is a child who's been brought by the mother, the second picture, brought by the mother. You see if the mother is dark and the child is also dark. But looking at that hand without the mother's hand, you'd really not say that this child has pallor or has anemia. So always compare with the mother's hand. Don't compare with your hand. Don't compare with other hands that you've seen. Always compare with the mother's hand because that is most likely the color of the child. And then you can always ask the mother, is this child usually this pale? Or have you noticed any color change from this child? And most of the times the mother will tell you, just like in dehydration, we don't tolerate, there are some people who have sunken eyes normally. So ask the mother, do you think the eyes of this child are more sunken or are their eyes always like this? And the mother is going to be able to guide you, and then you'll make, as you make your own assessment and conclusions. So to make decisions to use or not to use, to transfuse, to use fluids or to use oxygen, or to use the blood or to use the fluids. Of course, for the fluids, you consider what is this child having? What is this child having? How severe is the circulatory problem? You know, is the problem likely to cause any diarrhea? You know, or is this, has this problem caused any diarrhea? If maybe their circulation has been affected, they are dehydrated because they have been diarrheaing or they have been vomiting. Of course, you first use fluids before you rush to blood. Or is there any severe malnutrition? Or does this child have severe anemia? And this anemia, for how long has it been? So do you need to transfuse immediately, or do you need, can you be able to buy time by giving fluids? And then if you need to transfuse, what do you want to transfuse with? If you transfuse with whole blood, are you going to, you know, to do a cardiac overload on this child? So do you need packed cells or do you need full blood? That one, of course, from the assessment of the child and from the clinical presentation of this child and how the generally the investigations that you have done from the lab, it's going to guide you. Also, take note that trauma, burns, and anaphylaxis must be identified if those are the core causes of this problem, and you treat them because this child, of course, needs to be treated fully. And if the child has chronic heart diseases, of course, you have to be very careful when you're giving your fluids or your blood. So in the circulation, how do you assess for circulation? First, you have to consider if there are signs of life or if there's a pass. Of course, you take your large passes. Are they very fast or are they very slow? And then you take your peripheral passes. Are they present? And if they are present, how strong are they? Are they weak? And then you take your temperature gradient. Of course, you take your temperature gradient starting from the upper arms and the lower arms. Check how far the temperature gradient is, and always remember to record. Then take your capillary refill time. Of course, don't be very fast. Always take like 5 seconds when you're taking your capillary refill. And then this child, are they having any sunken eyes, or how long is it taking for the skin pinch to go back? Does this child has any pallor? Do they have any severe wasting or edema? Of course, that one is going to guide you. Everything that you see guides you in how you're going to manage this patient. So it monitors for assessing the saturations, you know, like our pulse oximeter, the heart rate. There are some people who have the blood pressure machines for the baby. If they are available, don't hesitate to use them. Always make use of everything that you have. So in case if there's diarrhea, are they severely impaired? You know, have they gone into hypovolemic shock? And then you check for all the other features. How alert are they? You know, your AVPU, are they alert? If they are not alert, are they responding to verbal, you know, your verbal stimulation? If not, have they gone into, are they responding to any pain? If they're not responding to pain, that means they are already unconscious. In case they are less than A, if they are less than alert, know that you might be dealing with hypovolemic shock. Then how is their peripheral passes? Is it weak or absent? The coldness of the skin, we talked about the temperature gradient, check on their temperature gradient. The capillary refill, how long is it taking for the capillary refill? Is it more than 3 seconds? Do they have any sunken eyes? And is the skin pinch taking long to go back? You know, the skin pinch, how fast is it going back? Is it taking more than 2 seconds? If you're having hypovolemic shock, give 20 ml per kg of Ringer's lactate over 15 minutes. You know, for resuscitation, always give 20 ml per kg. That means you have to estimate the weight of the baby if you're not able to take it, of Ringer's lactate over 15 minutes. So if they're having severe anemia, of course, severe anemia is going to cause respiratory distress and impaired circulation. If there's severe pallor and there's any acidotic breathing or respiratory distress, even if there's severe impaired circulation, do not give bolus fluids. Give maintenance fluids only before blood. Why? Because this heart has been dealing with very low volumes of the fluid in the body. So in case you start now giving bolus, you're going to overwork this heart and you're going to be causing more harm than good to this patient. So in case there is a severe anemia, give 10 ml per kg packed cells or 20 ml per kg whole blood. Start urgently and transfuse over 3 to 4 hours. For the same reason, we don't want to overload the heart. So in case there is severe impaired circulation, but there is no diarrhea, there is no severe anemia, and it's with or without severe malnutrition, if the infant has all that, all of these, that is AVPU less than A, has weak or absent peripheral passes, and there's coldness of the skin, the cap refill is taking more than 3 seconds. You're supposed to give 20 ml per kg Ringer's lactate slowly, that is over 2 hours, because fast bolus may do harm. Then use Ringer's lactate with 5% dextrose in case you're dealing with a case of severe malnutrition. So in case we have impaired circulation with no diarrhea, no severe anemia, and without severe malnutrition, and this is the same thing that we have talked about. Repeated. Here the only insistent is do not give the boluses, give of course over a long period of time. So in case you're not having a patient with trauma, this is a patient who's not bled acutely, you're supposed to give fast bolus of 20 ml per kg. You're supposed to give 20 ml per kg Ringer's in 15 minutes, if only it's only used in the area that is complicated by severe impaired circulation. This is a child who's come to you in shock, and then there's severe impaired circulation in other febrile children, or in severe malnutrition, you treat with 20 ml per kg Ringer's lactate, that is over 2 hours, and then blood is needed urgently for severe anemia with acidotic breathing or respiratory distress, and even if signs suggest impaired circulation, which is not severe in a febrile illness, just give the maintenance fluids. Don't be tempted to give the boluses. This is a summary of the fluids that you're supposed to give. Just what we talked about: diarrhea with severe impaired circulation, that is the hypovolemic shock. Give a fast bolus of 20 ml per kg Ringer's lactate over 15 minutes. In case the child is severely impaired, has no diarrhea, no anemia, you're supposed to give 20 ml per kg Ringer's lactate over 2 hours. You can do it, you can alternate with 5% of dextrose in case they have severe malnutrition, impaired circulation, no diarrhea, or without severe malnutrition, you just give them maintenance fluids. So in the disability assessing for the B, you use the AVPU to determine if dextrose is required. You'll have done, of course, your RBSs, and in case they have very low sugars, you'll be surprised. This child came the way they came, or they are presenting very sick, very weak, and it's only their sugars which are low. And after you give you the sugars, actually a child you thought was unconscious wakes up and is alert, and you know, you didn't think that it's a child that you had seen a few minutes ago. So maybe I can take a few questions before the next presenter. Any clarification or any questions that you might be having? If there are no questions, we can go to the summary of what we talked about. So in summary, we've said anytime you get a child maybe who is ABPU less than A, you're supposed to get help, don't work alone, and then check on their airway, look, clear, and position, and then check their breathing. You need to supplement with any oxygen, check their circulation, and use the correct fluids. And in case you need blood, of course, get the fluid, get the blood urgently. And thank you for your patience. I'm going to welcome Georgina and Rachel to take us through triage.
Do you want us to click on to the next slide, or so you want us to select the
Hi everyone, I'm Rachel Mackenzie and this is
Georgie.
We are two nurses that have come from Bristol. We've come for the week to see your department, and this is going to be an interactive session that we're going to talk about triage. So we'd like to find out a bit more about you guys and what you think about this, and we're going to discuss a bit about where we've come from and what we do as well.
So we're going to initially discuss what you guys think triage is, and then we're going to look through the definition of triage. We're going to talk through different triage priorities, who would be appropriate to see where, and then we're going to discuss some different scenarios and how you've implemented it into real life situations, and then we'll take any questions and we'll summarize at the end.
So what do you think triage is?
So anyone that works in triage that's happy to share what they feel from their experience triage means.
Nobody has worked in triage.
It is something else. You identify the patients who need care.
Amazing.
Yeah, you'd say the same. So on the next slide. So the World Health Organization define it pretty much what you've said. Triage is a sorting of patients into priority groups according to their need and the resources available.
So taking from that, we've looked into priorities, so prioritising patients. So one of the ways that we prioritise is we do their observations, and so we'll do a blood pressure, a heart rate, a respiratory rate, oxygen saturations, temperature, and we will use a Glasgow Cone scale just to see how alert and orientated the patients are. We would also use clinical information as well, so we will take a history from the patient and find out, say, if they've got chest pain. We might ask them how long they've had the pain for, what sort of pain it is, and ask them and we also are going to look at the patient as well and see what we think. That's a good way of assessing a patient, is always to be looking at your patient.
So the World Health Organization have categorized triage priorities into 3 different categories. So an emergency, a priority, and a patient booking queue. So an emergency is someone that needs life-saving treatment imminently. So that's someone that in our department we put into research, and we've noticed from observing what you guys did, they go into your emergency department. Someone that needs immediate treatment there and then. A priority is someone that needs a rapid assessment. So it might be somebody that's currently stable but has potential to become quite sick, or somebody that can't wait a really long time to be seen. And then somebody that could queue. So this is a non-urgent case. It might be something that's an ongoing condition, but they are stable patients. From what we observed yesterday, these are patients that tend to be seen in your outpatients department, we believe. And we saw yesterday that when you had someone that was a priority that didn't need the emergency department, that someone went and discussed it with one of the clinicians, and they were seen as a priority by the outpatient. So that's kind of how we've seen it happen yesterday.
So yeah, we're going to talk about some scenarios. Our scenario 1 is that we have got a 20-year-old male. He's presents with diarrhea and vomiting, and he's known to have type 1 diabetes. So his observations are blood pressure is 118 over 78, his heart rate 80, respiratory rate 22, temperature 36.8, and his SATs are 99%, and GCS is 15. He's alert and orientated and talking. So what priority do you think this patient would be, and why, and where do you think they might be seen? Does anyone have any ideas about where any of this? You think it would be an emergency? Non-urgent.
What makes you think that they would be non-urgent? Is there any kind of what people's thought process is behind that? Is there anything that you might that would concern you about this patient at all?
Sorry?
Yeah. Yeah.
This is a patient with a diabetic, and you're worried about the vomiting and their diarrhea. The sugars will go very fast.
Yeah, that was something that we were concerned about. So we would be quite concerned about a patient that's a diabetic. So if they've had diarrhea and vomiting in the diabetic patient, this can turn into an emergency. So this is something we might be concerned about. We would think that they could be seen in the emergency department, or like prioritised. But
That's just from our experience at home. We become quite worried that our diabetic patients that have diarrhea and vomiting have the potential to go into DKA, so diabetic ketoacidosis, which can be a life-threatening emergency. So we like to see them as a priority. But I think if they queued them and their blood sugar was okay and someone was aware of the patient, that would also be an appropriate place for them to be seen if they were seen in our patients.
definitely, because their observations are normal. So yeah.
So sorry, it will change the priority depending on the glucose level. Is that right? Or
So I think if their blood sugar was very high, that would definitely give us
so
more
we will do a
concerns.
glucose level in the triage, and then depending if it's normal, maybe it's not urgent, but if it's very high, you will think it could be DKA. Let's treat it as urgent. Is that right?
Yeah.
Okay.
Yeah. Thank you.
So scenario number 2 is a 28-year-old male. He's presented with chest pain. He's got no medical history that he's aware of. His blood pressure is 122/68. His heart rate is 65. His respiratory rate is 16. His temperature is 36.1. His oxygen levels are 99%, and his GCS 15 alert and talking. What priority would this patient be? where do you think they would be seen? Is there anything you're worried about? So I'm sorry, so I'm going to say something.
But the queue.
Yeah. Yeah. So we would do the same thing. We would view the patient, they sound very stable. There might be some questions that we might ask about, like risk factor, if they've got any heart problems. But yeah, I agree. But we think we would see them in our equivalent of like outpatients as well, in our department.
Just one question.
Yeah.
Can we go back to the, so in this case and scenario, exactly the same observation, exactly the same presentation, but the patient rather than 28 is 82, so we change the number. That would have changed your priority or not? We go against it.
What's everyone think? I see some nodding. So I think for me, if they were older and they were in their 80s, I'd be more concerned. They've got probably higher risk of having an acute cardiac event going on.
But the fact they've got no past medical history at 82 is quite reassuring.
Yeah.
I think a lot of it depends on your patient at the time.
Yeah.
So like, how does your patient look? Something that we would do is an ECG on this patient, and that would be a big decision in our factor of how much of a priority this patient would be. So that would be a big factor in our decision making.
Okay.
Yeah.
So
ECG at Triage.
Well,
as soon as possible, I think.
Yeah.
So
Not
we
impossible to do that.
yeah.
I'm not saying it's not, I'm just saying.
Our setup.
To make triage more feasible.
Yeah, so what we have is we have a nurse that triages, and then a nurse that does kind of the jobs from the triage nurse. So we would highlight to them, could this person have a blood sugar, could this person have an ECG, and they do any urgent jobs that might change kind of the path of where the patient might go. It's how it works in the BRI with us. So
say that we don't mind moving between triage categories.
Yeah.
So the patient for us with an ECG, the doctor might sign ECG or look at it to say it's not a myocardial infarction, and then the patient can queue because we've excluded the one thing that we were worried about, the elderly patient chest pain. So you can upgrade or downgrade the triage depending on what you find with that person.
So onto our third scenario. So we've got a 42-year-old female presents with palpitations with no past medical history. So her observations are her blood pressure is 120/64, her heart rate is 180, her respiratory rate is 17, temperature 36.2, SATs are 99, and again her GCS is 15 out of 15. So what priority would this patient be and why, and where would they be seen?
Yeah. Lovely.
So we thought that they should be maybe in an emergency with a very, very high heart rate and seen in the emergency department.
So you've got a 30-year-old male who's presented with some abdominal pain. As far as we're aware, they've got no medical problems. Their blood pressure is 95/53. Their heart rate is 100. Their respiratory rate is 18. Their temperature is 38.2. The oxygen saturation is 99%, and their GCS 15 and less are talking. Did I hear a few people say emergency? Yeah. Any other thoughts about what you? Is everyone in agreement with that, or?
The blood pressure is quite low.
Yeah.
Yeah.
Blood pressure is low.
Yeah. reduce all potential.
Yeah.
Yeah. Consider this as an emergency.
Yeah.
And,
So this is someone that
no, it's
we had could probably go either way. So a lot of it might be based on how they look. So it might be the fact that although their observations are a bit abnormal, that nothing's immediate, like life-threatening, they might be a priority. But equally, if they're sat in front of you, they're clammy, they're sweaty, they're looking unwell, they might be someone that you would send to the emergency department. I think this would be like on a case-by-case basis, depending on how the patient presented in front of you. So at the time when we were discussing it last night, we were kind of picturing someone that could be seen in outpatients as a priority, but I see why you would see them in an emergency department. I think that'd be just as appropriate because they are hypertensive, slightly tachycardic, and they do have a fever. So I think, yeah, you'd base it on presentation in front of you at the time.
Okay, so this is scenario 5. This is our final scenario. We'll be pleased. Okay, so we've got a 51-year-old male. He presents with shortness of breath and he's got no past medical history. So his observations are 125/63, his heart rate is 71, respiratory rate is 23, temperature is 36.2, his oxygen saturations are 80%, and his GCS is 15, so he is alert and orientated. So again, what priority do we think this patient and why, and where do we think they should be seen? Yeah. Yes. Yes. Amazing. Yeah. So yeah, again, this is what we thought as well with an emergency. Yeah, with the very low oxygen saturations, we would be concerned this could be a life-threatening, and we would want patients to have oxygen straight away. Is something that we would be thinking in this situation in the emergency department, and getting that oxygen on to bring those oxygen saturations up.
Has anyone got any questions?
One question: do you prompt any intervention from the doctor or the nurse, or you by yourself directly from triage? For example, in this case, you would put the patient in the emergency category of triage. But will you start the oxygen therapy straight away?
Yeah.
Yourself?
Yes.
With
As a
oxygen,
nurse?
as oxygen levels low as 80%, we would definitely
You will,
just want
right?
to get
Straight away.
oxygen straight onto that patient.
So there are interventions, like
Yeah.
critical interventions that you can make directly from triage
Yeah.
in order to improve or put the patient in the right direction.
Yeah, so if it was that low, rather than waiting and speaking to one of our clinicians, I'd put them on oxygen, and then I would go and tell somebody I've moved them to an appropriate area, I'd put the patient on oxygen. Could someone go and assess the patient urgently? Any other questions?
comment.
Okay, so just to summarize, triage is essential to identify sick patients so they can be directed to the emergency department, and this can save lives.
We just want to say thank you to everyone. We felt so welcome coming here, and it's been lovely meeting lots of people, and we look forward to meeting the other people that we haven't seen yet and seeing a bit more of the emergency department and other areas within the hospital. Thank you.
Thank you.
So thank you once again to the presenters. And also, even for the short period of time we discussed with you to make the presentation together with our